So this is Chapter 57, Ophthalmic Drugs. It is ATI Chapter 14. It starts on page 916 in your book. Again, we're going to talk about anatomy and physiology of the eye, disorders and disease processes that can happen with the eye, and the various classifications of ophthalmic drugs that are used to treat those disorders. And then we'll talk about nursing care for patients receiving ophthalmic drugs. So as far as anatomy and physiology of the eye, the eyebrows protect the eye from direct sunlight, or direct light anyways. Any types of dust or small particles that might fall into the eye, or perspiration coming off the brow. The eyelids cover and protect the anterior eye, which is the front of the eye, and the eyelashes prevent small particles from falling into the eye as well. The papillary fissure is the space between the upper and lower lids. The sclera is a tough fibrous tissue that covers the entire eyeball, and it helps to maintain the shape of the eye. The uvea is a fibrous tunic that's beneath the sclera. It includes the iris and the choroid and the ciliary body. The choroid contains the blood vessels that supply the eye. It also absorbs light. The iris is the colored part of the eye, and then the ciliary body is the structure that supports the ciliary muscles that control the curvature of the lens. And then the conjunctiva is the mucous membrane that lies that lines the eye and covers the exposed anterior surfaces of the eyeball. And the pupil is the center of the eye, or the center of the iris, and that allows the light to enter in through the eyeball. The medial canthus is the site of union of the upper and lower eyelids near the nose. The lacrimal carbuncle is a small little red elevated covered spot that's right in the corner of your eye there at the medial angle of the eye, and that's where the lacrimal glands are located, and the lacrimal glands are the ones that produce tears. And then the lateral canthus is the site of union of the upper and lower lids on the other side away from the nose, so closest to your ears. So the front of the eye is covered by 3 different layers, all protected by the eyelid. The external layer is a protective layer, and that is the cornea and the sclera. And then the middle layer has the choroid, the iris, and the ciliary bodies. And then the inner layer is where the retina is, which is light sensitive. As far as muscles, there are 4 types of muscles. They're inferior, superior, medial, and lateral. So inferior would be bottom, and superior is top. Medial, middle, and lateral is on the sides. So those are the 4 rectus muscles, and then there are 2 obliques, and they are inferior and superior. And these muscles are all responsible for movement of the eyeball. So the interior eyeball has the interior and posterior chambers, the canal of Schlemm. Here's where aqueous humor and vitreous humor are as well. The aqueous humor is a clear, watery fluid that circulates in the anterior and posterior chambers of the eye. The aqueous humor is removed from the anterior chamber through the canal of Schlemm. The vitreous humor is also a fluid component of the vitreous body. Since the eyeball has very limited space, any types of small changes in volume of the aqueous humor can lead to a change in intraocular pressure, whether that's increased intraocular pressure or decreased intraocular pressure. The retina is the innermost layer of the eye, containing both rods and cones that receive visual stimuli and transmit them to the optic nerve. The rods are responsible for black and white vision and peripheral vision, so the vision on the sides. And then the cones enable the person to see colors and then play a large role in central vision, or the vision that's in front. And then the optic nerve stimulates the visual signals to the brain. The lens is a usually transparent curved structure of the eye that is located directly behind the iris and the pupil and is attached to the ciliary body by ligaments. Accommodation is the adjustment of the lens for variations in distance. And then here in the picture you see a cataracts, and this is an abnormal progression of loss of the transparency, and then it results in a blurred vision. The sphincter pupillae muscle is controlled by the parasympathetic nervous system, and it constricts the diameter of the pupil, and this is called miosis. And then the dilator muscle is controlled by the sympathetic nervous system, and it will dilate or open the pupil, and this is called mydriasis. Medications used to treat disorders of the eye are divided into several drug groups. There's anti-glaucoma drugs, antimicrobials, anti-inflammatories, topical anesthetics. The list can just go on and on. We'll be discussing each of these groups throughout the lecture, including the drugs that are listed here on the slide. So we'll be talking about the mydriacs, which dilate the pupil, and the miotics, which constrict the pupil, and then the cycloplegics, which the name implies, if they're pelegic, they paralyze the ciliary body. So we'll talk about all of those coming up. So this is a list of the group of drugs used ophthalmically. Again, those glaucoma drugs, antimicrobials, and anti-inflammatories. The topical anesthetics, diagnostic drugs, which could be used to either dilate or constrict the pupil so that some testing can be done. Also, those paralytic drugs will be used as well, or anesthetists, so they can check things out a little bit better. And then there's also lubricants and moisturizers, and this includes things like contact lens solutions and eye washes as well. So first we'll talk a little bit about glaucoma. There is a group of eye disorders. This is a group of eye disorders that damages the optic nerve. Inhibition of the normal flow or drainage of aqueous humor is the problem, which results in an angular pressure. Pressure against the retina then destroys the neurons, which leads to impaired vision and then eventually to blindness. The two major types of glaucoma are open-angle glaucoma, which develops slowly and is genetically determined. It does not involve a narrowing of the angle between the iris and the cornea, so the anterior angle remains open, but the canal of Schlemm is obstructed by tissue abnormalities causing problems with drainage. And when the aqueous humor can't drain, that causes that change in the amount of fluid that's in the eye, and therefore increased intraocular pressure. Then angle closure glaucoma is caused by a narrowed anatomic angle between the lens and the cornea, and this prevents the fluid from exiting the eye through the canal of Schlemm, which again causes that increased intraocular pressure. So treatment of glaucoma involves reducing intraocular pressure, and this is accomplished by either increasing the drainage of the aqueous humor or decreasing the production, or it could be a combination of both. Certainly the desired effect for all glaucoma medications is to decrease the intraocular pressure. So some of these drugs include direct acting cholinergics, indirect acting cholinergics, adrenergics, anti-adrenergics, carbonic anhydrase inhibitors, osmotic diuretics, and then prostaglandin agonists. So the cholinergic drugs, these mimic the parasympathetic nervous system neurotransmitter acetylcholine. These are also called miotics, or they're also called the cholinergics. The direct acting, they could be direct acting or indirect acting, and there's a little picture here that will kind of show you how those different drugs kind of work. That's the picture to the right on the slide. But they cause pupillary constriction or meiosis, which leads to a reduced intraocular pressure caused by the increased flow of the aqueous humor. The direct-acting miotics directly stimulate the ocular cholinergic receptors and mimic the acetylcholine, and then the indirect-acting work by binding and inactivating the enzymes that break down the acetylcholine. So the direct-acting drugs include acetylcholine or Mycol-E, Carbocol or Carbonic, Pilocarbine or Pilocar, and then the indirect acting is the phospholine iodine. And the phospholine iodine is currently the only drug in this class available. The direct and indirect acting miotics are used for treatment of open-angle glaucoma, angle closure glaucoma. They're also used in ocular surgeries, and then they're also used for convergent strabismus or the cross-eyedness. They're also used to reverse the effect of mydriatic drugs after ophthalmic examinations. Table 57.3 on page 922 gives a more specific indications for each one of these drugs in this class. So for adverse effects, they're mostly limited to local types of effects, although pretty rare in sufficient amounts. If sufficient amounts enter the bloodstream, certainly systemic effects may occur. They're actually more likely to happen with the indirect acting medications, and those signs and symptoms would include hypotension, bradycardia or tachycardia, headache, nausea, vomiting, diarrhea, abdominal cramps, and certainly asthma attacks as well. Some of the other undesirable effects can include temporary stinging upon installation, reduced low light vision, so harder to see when the light is lower at night, conjunctivitis, tearing or lacrimation, and then twitching of the eyelids. So the sympathomimetics mimic the sympathetic neurotransmitter epinephrine and norepinephrine and stimulate the dilator muscle to contract, which results in an increased pupillary size. This will enhance aqueous humor outflow through the canal of Schlemm, and then intraocular pressure is then reduced. Alpha receptor stimulation causes dilation of the pupil, which decreases aqueous humor formation and increases outflow. And then beta receptor stimulation has little or no pupillary effect, but it still decreases the aqueous humor formation. So again, both of these can work to decrease intraocular pressure. So the sympathomimetics include the alpha receptor agonist, alpha-GAN-P and iodopine, as well as alpha and beta receptor agonists, epinol and propine. So these drugs are used to treat chronic open-angle glaucoma. They are also used in reduction of postoperative intraocular pressures, and then also for reduction of ocular hypertension. They're also used during ophthalmic surgeries to correct the surgery-induced type of elevations in intraocular pressure. So the adverse effects are again primarily limited to ocular types of effects, so burning, eye pain, lacrimation, which is tearing, Some of the other effects may be conjunctival hyperemia, localized melanin deposits in the conjunctiva, and release of pigment granules from the iris. Although, again, very uncommon, systemic effects can happen or are possible, and those would be hypertension, tachycardia, extrasystoles, headache, or faintness. Another group of drugs used to reduce the intraocular pressure are Beta-Adrenergic Blockers. The selective beta-1 blockers include Beta-Oxalol or Bioptic, and then Beta-Oxon, I can't even pronounce that one, sorry guys. The non-selective beta-1s and beta-2 blockers, Ocupress, Betagan, Optopranolol, and Timoptic are pretty common. Timoptic is probably one of the ones that I see most often in practice. So these drugs work to reduce intraocular pressure by reducing aqueous humor formation, and they also increase the outflow. These drugs do not affect pupil size or accommodation or night vision. So indications for the beta blockers. These drugs are used, again, to reduce elevated intraocular pressures in chronic open-angle glaucoma and ocular hypertension. They also might be used to treat some forms of angle closure glaucoma. So the most common ocular effects are transit burning and discomfort. Other effects are blurred vision, pain, photophobia, and tearing or lacrimation. Again, because these drops are administered topically, systemic effects are not really suspected or expected to happen. They're very rare. I guess they are possible, but not really an expected thing to happen. If there were systemic effects, they would include headache, dizziness, cardiac irregularities, and bronchospasms. So theoretically, ophthalmic beta blockers can have additive therapeutic and or adverse effects when given systemically or given with systemically administered beta blockers or other cardiovascular drugs. So if a patient's already taking orally some type of beta blocker or other type of cardiovascular drugs, and then they're given these eye drops, then theoretically, again, there could be additive effects. So you want to be careful about that. The carbonic anhydrase inhibitors, these two drugs are available in topical form only. They're oral. There are oral carbonic anhydrase inhibitors that are sometimes used for glaucoma as well. These drugs are sulfonamides, so they should be used with caution in patients who are allergic to sulfa antibiotics. And the two that you'll see most are the Azopt and Tresopt. So the carbonic anhydrase inhibitors inhibit the enzyme carbonic anhydrase, which reduces the aqueous humor formation in the eye. And then again, because we have a decreased production, that will result in decreased intraocular pressure. So this this class of drugs is primarily used for the treatment of glaucoma, both the open angle and the angle closure. It also is used preoperatively to reduce intraocular pressures. So again, because it's a topical medication, systemic adverse effects are possible, but unlikely. Oral forms of these medications can produce systemic effects, such as drowsiness, confusion, transient myopia, tinnitus, anorexia, vomiting, diarrhea. There are several others. Again, patients with sulfa allergies may develop a cross-sensitivity, so we want to be sure to screen patients for sensitivities to sulfa drugs. So osmotic diuretics create ocular hypotension by producing an osmotic gradient. So the water is forced from the aqueous and vitreous humor into the bloodstream. And this results in a reduced volume of intraocular fluid and then reduces intraocular pressures. The most commonly used osmotic diuretics used to reduce intraocular pressure are glycerin and mannitol. They can be administered IV, PO, or topically. The glycerin is usually tried first. It can cause hyperglycemia, so we'll need to be monitoring blood glucose levels. Mannitol is then used if the glycerin is unsuccessful. Isosorbide and urea may also be used after glycerin and or mannitol have failed. So indications for use are acute glaucoma episodes, before and after ocular surgeries to reduce intraocular pressure. Some of the adverse effects include nausea, vomiting, and headache. May also cause fluid and electrolyte imbalances because they are a diuretic, so we need to monitor those as well. Other effects are possible, such as irritation, thrombosis at the injection site, so we want to monitor those as well. So the prostaglandin agonists, these are the newest class of drugs that are being used for glaucoma. There are 3 drugs in this class, the xanthan, or Zalatan, Trevantin Z, and then the Lumigan. The Zalatan and the Lumigan are the ones that I have seen most often in practice. So the prostaglandin agonists reduce intraocular pressure by increasing the outflow of the aqueous fluid between the uvea and the sclera, as well as via the usual exit through that trabecular meshwork. They're used in the treatment of glaucoma, and most drugs allow for single dosing a day because the effects last from 20 to 24 hours, so they're a convenient type of drug to use. So they're generally tolerated well, but they can cause stinging and bloodshot eyes, blurred vision, itching, and burning. Systemic effects, which again do not happen very often, include skin reactions, upper respiratory infections, and headache. They can have effects on eye color, so in some persons with hazel, green, or blue-brown eyes, eye color will change permanently to brown. And the color change occurs even if the medication is stopped. These drugs, the ocular antimicrobial drugs, are used to treat infections. They can be given topically or systemically. Some of the antimicrobials include antibacterial drugs, antiviral drugs, and antifungal drugs, and then the choice of which of these drugs to use is really based on the type of infection, sensitivity and response of the patient, cultures and sensitivity, as well as clinical experience of the provider, who knows what may or may not work with the different types of infections. Topical application may cause some transient and local inflammation, burning, and stinging. Use of ophthalmic antibiotics with corticosteroids may make it more difficult to rid the eye of infection because the corticosteroids have an immune suppressive effect that can impede the therapeutic effect of the antimicrobials. So the antibacterial drugs destroy bacteria by interfering with the protein synthesis in the bacterial cells. Aminoglycosides are a type of antibacterial that are used, so gentamicin, tobramycin. Adverse effects include swollen eyelids, local erythema and mydriasis, overgrowth of non-susceptible organisms that can lead to infections that are resistant to treatment. So again, antibiotics don't only kill the bad cells, they kill the good ones that we certainly need, and then they also will maybe not control the non-susceptible organisms, so there could be a problem with increased infection. So the macrolides are antibacterials. They're erythromycin, azithromycin, and some others. Erythromycin is also used in the prevention of Neisseria gonorrhoeae eye infections in newborns, and also to treat neonatal conjunctivitis caused by chlamydia. So there's the eye creams that they use, or those right after babies are born. The polypeptides, also antibacterial, so this is the bacitracin or the polymyxin B. These drugs are most commonly used in the treatment of superficial types of infections caused by gram-positive bacteria. Quinolones, these are very effective broad-spectrum antibiotic that destroy a wide variety of organisms that are very often difficult to treat. Significant adverse effects include formation of corneal precipitates during the treatment for bacterial keratitis. Other reactions include corneal straining or infiltrates. These drugs work by blocking the synthesis of folic acid in the susceptible bacteria. They're used to treat conjunctivitis and other types of ocular infections. Some of the adverse effects are limited to local irritation and stinging. Sulfonamides can also result in overgrowth of non-susceptible organisms. Some of the common ones that you'll see are the ciprofloxacin, the Zymar, Vigamox, Quinix, Ocuflox, the Blef10 are sulfonamides, and then the Blef10 is what I see most often, but the Gandricin you may also see. So anti-infungals destroy fungi in the eye, and they're only available in a suspension form, and they're used topically to treat blepharitis, conjunctivitis, and keratitis. And the one drug that is in the book that they talk about is the Natacin. So the Vitracert and the Vitrine are antivirals, and they're used to treat viral infections in the eye. There was not much information when I was reading, but it did mention that these are administered by a surgical implant in the ophthalmologist's office. So there's not any more information in your book in regards to these medications. If you have questions, we can look at them individually if you're interested in knowing a little bit more about them. So the trifluridine inhibits viral replication and is used for ocular infections, keratitis, keratoconjunctivitis caused by type 1s and type 2 herpes simplex virus. They're applied topically as drops. There are significant adverse effects which include secondary glaucoma, so they can cause an increase in the interocular pressure, corneal punctate defects, uveitis, stromal edema, which is edema in the tough fibrous transparent portion of the cornea. So those can all happen when using these antiviral drugs. So anti-inflammatories, first we'll talk about NSAIDs. So those are like ketorolac, the Ocufen, the Brofenac, and Voltaren. Many of these same anti-inflammatory drugs are used systemically and may also be used ophthalmically to treat various ocular inflammatory disorders. These drugs not only include NSAIDs, but they also include corticosteroids. So the corticosteroids include drugs like dexamethasone or Decadron, Retisert, Fluoropt, Lotemax, HMS, Predforte, and Vexol. Corticosteroids are used during the acute phase of the injury process to prevent fibrous scarring, which can result in visual impairment. So when tissue is damaged, the membranes of the affected cell release phospholipids, which are broken down by enzymes within the arachidonic acid metabolic pathway. So these anti-inflammatory drugs act on various parts of that pathway, which reduce the production and of the various inflammatory mediators, and as a result, pain and erythema and other inflammatory processes are reduced. So the ocular anti-inflammatory drugs are also used to treat corneal and conjunctiva and sclerosis, such as chemical or thermal burns, or other injuries that can be caused by foreign bodies. The most common adverse reactions are transient burning or stinging with application. Long-term corticosteroid use can lead to cataracts, increased ocular pressure, and optic nerve damage. So they have to be monitored very carefully if they're going to have any type of long-term corticosteroid use. For ophthalmic anesthetics, the two pretty common ophthalmic anesthetics currently on the market are the prilocaine or alkane, which I see very, very often, and then the tetracaine. These are used to prevent eye pain during surgery, during different types of examinations, removal of foreign bodies or structures. So it can be used to help control pain for these eye injuries or control pain when they have a foreign body. They can be used for diagnostic testing and procedures. They're really for short-term use only, and they are not recommended at all for self-administration. The problem is that prolonged use may produce permanent corneal opacification, which will lead to visual loss. Adverse effects are usually local effects such as stinging, burning, redness, tearing, and blurred vision. Again, with all ophthalmic drugs that are applied topically, systemic effects are rare, but certainly are possible. Systemic adverse reactions to the topical anesthetics include CNS stimulation and or cardiovascular depression. So the diagnostic drugs, these drugs are used to dilate the pupil and paralyze the ciliary muscles, which prevent accommodation. Atropine is used during eye examinations and also to treat uveal tract inflammation problems. The cyclogel is primarily used for diagnostics. It's not really used at all to treat uveitis. This causes mydriasis and then the cycloplegia, and it's actually, again, just used for those diagnostic types of examinations. So other cycloplegic mydriatics include scopolamine, homatopine, and topicamide. I know you guys love it when I do that. Both the scopolamine and the homatropine, I'll get it right one of these days, are used for both diagnostics and to treat uveitis, where the tropicamide, like the cyclogel, is only used for diagnostics. So the ophthalmic dyes, this is known as fluorescein. These are, or called fluorescein, these are used to identify corneal defects and to locate foreign objects within the eye. They're also used sometimes for fitting hard contact lenses. What happens is they put this dye in the eye, and then the various defects are highlighted in either a bright green or a yellow-orange. And foreign objects have this green halo that are around them. So they'll put this dye in the eye, and then they'll look at the eye with a light, and then they'll be able to see these highlighted areas to identify where the problem is. Ophthalmic antihistamines are used to treat symptoms of allergic conjunctivitis, whether they're seasonal or non-seasonal, and these compete at the receptor sites for the histamines. Some examples of these are the Optivar, Patanol, Emidine, Zaditor, and Elisat. So other anti-allergic drugs, the mast cell stabilizers inhibit the release of inflammation-producing mediators from sensitive cells. These drugs are used to treat vernal keratoconjunctivitis. They're also decongestants, and these work by promoting vasoconstriction of the blood vessels in and around the eye. They are used to control redness, burning, and other minor irritations. As far as the lubricants and moisturizers, there are many of these products that are available over the counter. They provide lubrication or moisture for dry or irritated eyes. They're available in drops or ointments. Some of the brand names you'll see: Murine, New Tears, Moisture Drops, Tears Plus, Aqua Tears. There's just a plethora of them available over the counter. Restasis, this is an ophthalmic form of cyclosporine. It is an immune suppressant drug, and it's used to treat the keratoconjunctivitis sicca, or dry eyes. It can be used together with artificial tears, but these drugs need to be given 15 minutes apart if they are used in conjunction with one another. So we want to assess the patient's history, including medication history, and we want to assess for allergies for sure. For some of those drugs that we talked about have some cross-sensitivities, so we want to make sure that we know all of that. We want to assess their baseline vital signs and visual acuity, and perform a physical assessment of the eye and the surrounding structures. We want to document any abnormal findings that you might find. Is there any redness or swelling or pain, excessive tearing, any drainage or discharge, any changes or decreases in visual acuity, any history of trauma, were they wearing safety glasses when they were at work, those kind of things. And then we want to assess for contraindications to those specific drugs. So we want to be really clear that we know that there are no contraindications for giving them these medications. We want them to follow the specific guidelines for administration for each one of the different drugs. So you might have to look that up ahead of time to make sure that you know exactly how they're supposed to administer them so that you can do some really good teaching. We are going to tell them that we want them to avoid touching the eye with the tip of the dropper or container because we don't want to contaminate it. And then ointments are applied in a thin layer in the conjunctival sac. When applying eye drops, we have the patient look up to the ceiling and we place a drop in the conjunctival sac. Pressure may be applied to the inner canthus for at least 1 minute, and this will reduce the systemic absorption of these drugs. If more than one eye medication is ordered, we want to clarify the correct order and interval for the administration and the time frame required between administering each one of these medications. If the patient wears contact lenses, you also want to check and see if they should be removed during the treatment. with the eye medication. So they may not be able to wear their contact lenses at all while they're receiving treatment with these drugs. So you'll want to check in to see if that's what needs to happen, and make sure that they have a pair of glasses. Most people that wear contact lenses do have a pair of backup glasses, so we want to make sure that we know whether or not they're allowed to wear their contact lenses or not. We want to provide the patient and family with education on the correct procedures for administration of eye medications. We're certainly going to monitor for adverse effects, and then monitor for therapeutic responses to the therapy. Some of the nursing diagnoses associated with ophthalmic medications are acute pain, and this is related to eye disorders or to the eye disorder, infections, or inflammation that's happening. Deficient knowledge related to the condition and or medications, and then risk for injury related to the improper installation or improper use of these medications. So that's it for this lecture. If you have any questions, you can please post these questions in the discussion forum under questions. Again, just as a reminder, you can always email me, you can call me, or you can text me. We'll also have time in class to answer any questions as well.